My first stroke I had on, I think, February 2nd. So I remember we had a family dinner because my family all wanted to see me. I was sitting in the sitting room and they were all talking, and suddenly I see my arm going away out of my shoulder. My other daughter said to me, "Mom, Mom," and then I couldn't talk, and Christine called an ambulance.
The University of Ottawa Brain and Mind Institute is a virtual institute that brings together scientists from across the city. It allows clinicians to meet other clinicians who would otherwise not meet, clinicians to meet scientists who are exploring very similar diseases, scientists to meet clinicians to find out what the needs are in the field, and patients as well. There are patients that are part of it that inform the science and inform the clinical direction. Basically, it's a way of bringing us together to connect and to increase the output of science.
Science is pretty competitive, actually, right? Like you want to make new discoveries, right? And you want to, but you can't. Science can't be done in silos. It can't be done individually. It has to be done as a team. Like to really bring, the biggest discoveries. Or when you look at those papers in medical journals, they have, many authors on the list of the paper, because it takes a team of people really to come together to bring the best ideas forward and then to advance the field.
The University of Ottawa Brain and Mind Research Institute and the Ottawa Hospital Research Institute support trainees like myself. From a research perspective, I've met the most incredible mentors here, and the mentorship I've received here is really second to none. If it wasn't for people like Dr. Dalashahi, I would not have discovered my potential for academic medicine, and I probably would not be the aspiring young clinician scientist that I am today. And I really don't think I could get that opportunity anywhere else.
We want to bring people who are hit by stroke, who have their life changed, who have their families taken away from them, and give it all back. We want to give people a chance. We want to give people hope. We want to give people a cure.
Good evening, everyone, and thank you for joining us tonight. Bienvenue à toutes et à tous. I'm Ruth Slack, and on behalf of the entire team, I'd like to welcome you all to the second night of Brain Health Awareness Week, hosted by the University of Ottawa Brain and Mind Research Institute. And for those joining us for the first time, the objective of Brain Health Awareness Week is to raise awareness of brain health, of mental health, knowledge that is critically important to empower us to really look after our own brain health and those around us. Also, during Brain Health Awareness Week, you will have the opportunity to learn about the latest research happening at the University of Ottawa Brain and Mind Research Institute. And as you saw in our opening video today, that the University of Ottawa Brain and Mind, together with its partners, has a very vibrant stroke program. In fact, many of you may not know that Ottawa was the home of the Canadian Stroke Network, which was founded by Dr. Antoine Hakim. And this program really changed how stroke patients are being treated today in Canada and worldwide. And now, as a result of the work of this network, there's much more hope for stroke recovery today. And today you'll hear more from this stellar stroke team here at the University of Ottawa. During the session, I'm sure that you'll have a lot of questions, so please feel free to submit your questions and comments into the chat, and these will be submitted to the panel. And now it's a real pleasure to introduce our first speaker and moderator, Dr. Dar Dalashahi. He's a professor in the Department of Medicine and Epidemiology at the University of Ottawa and at the Brain and Mind Research Institute. He's a senior scientist at the Ottawa Hospital Research Institute. He's the vice chair in the Department of Medicine, which is the largest department at the Ottawa Hospital. He's a stroke neurologist at the Ottawa Hospital, and he's an international leader in this field, having over 200 peer-reviewed research publications on the topic of stroke and intracerebral hemorrhage. His clinical specialty and research focuses on treating stroke in the acute emergency setting. So thank you, Dr. Dar, for being with us this evening. We're really looking forward to hearing from you and the team.
Thank you very much, Dr. Slack, and hi, everybody. Welcome to my home office and to our evening's event with many of my excellent colleagues. I'm very happy to be moderating this event on behalf of the Brain and Mind Institute. So we're going to talk about stroke tonight, and I know some of you out there, I'm recognizing some of the names, and welcome back. And we have a lot of new people joining us, which is fantastic. We have a great, I think we have almost 90 people so far, and more joining by the minute. As Dr. Slack said, if you have your questions, I mean, if there's something absolutely burning that we got to address right away, I'm going to pick it out of the list of questions that you submit. But otherwise, if you enter them as we go in the Q&A, at the very end, we'll have a panel with everybody and kind of go through these questions and have a conversation. So I'm just going to start my presentation here. There we go. Okay. So I have to start by just giving a bit of background with the Brain and Mind Institute. The idea here is we have a great number of neuroscientists, brain researchers, clinicians, nurses, allied health throughout the city, all of which are very intent on moving their science and their clinical care forward and helping their patients and advancing the care of patients outside of our city and across the world, but in the past had operated in silos with the visions of Dr. Hakim and Dr. Park, and with the stewardship of Dr. Schlossbacher and Dr. Slack. What we've managed to do is create this institute that brings all of those silos together. These are all scientists and researchers of various backgrounds that would often only meet at an international setting. You didn't know that the person 2 blocks away from your own house was also a scientist doing something slightly different but related than you. Well, now you know, because the Brain and Mind has put us all in a room together. And now actually, ironically, with the pandemic, has even enhanced those networks, because we're now able to meet far more easily as we are right now. So that's what this institute has done. So here we're just going to get a taste of the stroke. And stroke, you can look at it as a continuum. There is the prevention side and the acute care, which happens in the emergency. And there's a lot of things that happen in a hospital. But then afterwards, there's a whole rehabilitation side and then a recovery side, which is lifelong for some people. So it's a big, long continuum. And sometimes there are some overlaps in the continuum. In Ottawa, what's happened traditionally is these things occur at different places. So the acute team is in the civic emergency, for example. The prevention is a different clinic. The medical could be at any of 4 or 5 hospitals across town that are doing the inpatient care. The rehab is at a very specific hospital, and then recovery, of course, happens all across the spectrum. So what the Brain and Mind has done is brought it all together. So now we're not just at different institutions. Well, physically, that's where we are and where we work, but academically, we're constantly in communication and working together. Focusing on what I do in the acute setting is what we call the stroke code. This is kind of the action, life and death side of stroke care for people. And it always starts on my end with my pager going off. And it's often seems to be at 2 or 3 in the morning when this happens. And I get a 0 on there. And the 0 basically means don't bother calling, just get your clothes on, get in the car and go. And we do have a unofficial rule of 20 minutes from time of page to when you're supposed to be moving into the hospital. So this is at all hours. And of course, on the patient's end, what could have happened is simply a person gets up at 2 in the morning to walk to the washroom, and then they're coming back and they collapse. And fortunately, their loved one hears the collapse, gets up, tries to get them up. They don't get up. They rush to the phone and dial 911, and that starts this process. So very scary thing. And what's happening in the hospital while I'm being alerted is we have a team that's waiting. They're already alerted that a person is coming and has just arrived. This is called a pre-notification system. That's why you dial 911 and don't go to the hospital on your own, because there's no way for us to know you're coming and you may go to the wrong hospital. The ambulance will take you to the correct stroke hospital. There's only one in town, and they will be pre-notified that they're coming. And so they're waiting for you. They get you on the gurney, rush you to the CAT scanner where there's a set protocol to follow. And the team, one of our team members is also here, one of our trainees who sleeps in the hospital during these. She'll talk to you briefly about her experiences. They identify this stroke, they identify the clot, and this is around when I start strolling into the emerge to catch up with the team. And then we start the treatment. And this is all rushed because in stroke, time is brain. When there's a clot in there, you're losing about 2 million brain cells per minute, and you don't have time for that to happen. So every minute counts. That's why we have all these parallel processes in place. So a typical story like this, from the point where the person collapsed, dialed 911 and arrived to the emerge, was 45 minutes. Within 5 minutes, we received the 0 codes for the stroke. And 26 minutes later, the person is receiving a clot busting medication to try and restore their independence and reverse the effects of the stroke. This is all from research. A lot of this research we did here. They're done everywhere, but we're all collaborators. And many of them we launched ourselves, like our Strive 30 project, where every single person that came in and got treated for stroke during those few years, we analyzed every step of the way. Who's picking the patient up from this gurney to that gurney? Who is plugging in the IV? Who is doing this? How is this being done? And we try to shave off a minute in every part of the process. And these are the types of research studies that we do every step of the way, whether it's coming into the emergency, traveling through the emergency, looking at the CAT scans. Everything is being included where possible in a research study so that the next time we do it the right way, the better way, the faster way, and the way that's going to make the bigger difference for the patient. So one example is a study that we call the ESCAPE study. And this took place between 2013 and 2015. If you, which is possible, or anyone you know had a major stroke during that time and got rushed into the hospital, you may have been part of this study, where this catheter that you see over here with a little mesh wire at the end went into the brain through a little puncture in the groin area, snagged that clot and pulled it out because of a hypothesis that this is the way that we should be treating strokes moving forward. Keeping in mind, before 2013, this was not known and nobody was really doing it, or if they were doing it, it was sporadic and with no clear direction. During 2013 and 2015, we were part of a large collaborative effort, a Canadian study, to do this in a systematic fashion and prove that it saves lives and takes out blood clots for people's brains like this. So here is what you'll see is a little mesh with a clot in it. And these are the clots that we pulled out of Ottawa people's brains. And I'll tell you, the brains really like us to have those clots on that table and not inside the brain. No question about it. The study made massive waves when it was published in 2015. It changed the entire world of stroke, and that's why we call it the post-2015 or the EVT era. EVT stands for endovascular treatment. That's basically means yanking clots out of brains. So the world of stroke changed at this date. And in fact, there was another 8 studies across the world that came right afterwards that said the same thing. And this is now standard of care. All this was happening right here. And that's where you hear, well, I heard this was going on in Germany and I heard that's going on in this center in the States. Actually, it's happening right here in Ottawa with the scientists of the Brain and Mind Institute. And often they're actually part of our studies. And it's interesting that you'll sometimes hear about stuff outside of your town without realizing it's happening inside your town. So that was a little bit of history, very recent history. But right now, there's a lot going on. Right now, if you or someone you know is unfortunate enough to have a stroke and you get to the emergency department, you may be receiving, in fact, a very high chance that you'll be receiving a new clot buster that's thought to be twice as effective and about 20% as dangerous as the one that we've been using for the past 20 years. There's a very good chance that you're going to receive these incredibly new and exciting neuroprotectant medications during your stroke to keep your brain alive while they're doing that procedure to pull the blood clots out of your brain. All these incredible, fantastic things that are going on. In fact, if you Google the neuroprotectants in acute stroke, you're going to hear about this fascinating thing that's going across 6 different countries right now with about 50 different sites. What you may not know is we just gave one to a patient at around 2 p.m. today here in Ottawa, and we've been giving it about 3 times in the past week already. So all of this is happening. And the next big frontier that I'll leave you with here is there's a whole type of stroke that we don't have a treatment for, the bleeding stroke, cerebral hemorrhage. Well, there's a major international effort called FASTES that's about to start, and it's going to be a new treatment in a new paradigm for people with this, what we can call an orphan stroke, because it has no treatment to date. And Ottawa is the national lead for Canada, and we are also, out of all the countries, 6 countries that are running this study, we're going to be the first to start. We expect to start in a couple of days. So there will be a treatment available for this disease under a research protocol here in Ottawa, nowhere else in the world within about a week. I thank you very much. And again, I'll tell you that this is only possible with the Brain and Mind Research Institute, that we can all get together and do these things. So I'm not going to take any questions. As I said, I'm going to save them to the end. But what I want to do is move to our next speaker. I'm just going to stop my sharing over here so that we can see everybody. I'm going to invite Sophia Gokan to join us. So Sophia, I've known for a very long time. She's one of our stroke prevention nurse specialists at the Champlain Regional Stroke Network and the Ottawa Hospital. We work together in a few capacities, the main one being direct patient care in the stroke prevention clinic, which is her specialty. But in addition to her clinical work, Sophia is also a researcher, also under the Brain and Mind Institute. She's been involved in research that focuses on neurological nursing assessment in the acute stroke setting, in the TIA diagnosis setting, and as well with factors that expedite urgent access to revascularization, that's repair of blood vessels when they're acting up. She's a member of the Nursing Research Work Group at the Ottawa Hospital. And I'm going to just pass it on to Sophia. Thank you.
All right, thank you so much, Dr. Jolette Shahi. So I'm really pleased to be able to speak with you today about stroke prevention research. And good outcomes in research and advances in care really rely on a strong and supportive team. And I'd like to acknowledge the really good company of partners in stroke prevention research that I'm grateful to work with, and the participation of public such as yourselves joining this virtual event, who support meaningful and transformative research work. The first, let's see if I can advance this. There we go. The first topic that I wanted to speak with you about is COVID-19 and its impact on stroke care in our community. At the height of the pandemic, our team and many teams provincially and internationally were really concerned about trends in care that we were witnessing. When following a declaration of a state of emergency in Ontario, it seemed that residents of our community were sheltering in place and staying home even when TIA and stroke events were taking place. So to promptly determine if our suspicions were valid and to look more closely at our local context, we did a rapid research review comparing our cases from February to April of 2017, 2018, and 2019 to what we were seeing in 2020. And what we found was that compared to prior years, in April 2020, there was a 28% reduction in stroke prevention clinic referrals. And this represents TIA presentations to our organization. As well, there was a 26 to 32% reduction in stroke codes or telestroke activations. And this represents a significant decrease in overall stroke presentations. One thing that we did see was that there was stable rates of TPA use with clot busting agents and stable rates of surgical clot removal. So this represents that patients with severe strokes were still presenting for care. While this latter information was reassuring, the decrease in rates of overall TIA and stroke presentations was quite disconcerting because TIA and minor stroke often warn of a serious stroke and provide us with an opportunity for critical preventive interventions. We suspected that these findings reflected a reluctance of patients with milder stroke symptoms to access healthcare services or emergency care due to fear of contracting COVID-19. However, people with more severe stroke were still activating emergency systems. So as a result of this research, our team really supported messaging to governmental agencies, to hospital administrators and patient advocacy groups and the public that stroke care is still necessary and safely accessible during COVID-19. Some of the media that supported this messaging in our community included Heart and Stroke Foundation, who promoted to the public, stroke is a medical emergency. Do not hesitate, call 911 even during the COVID-19 pandemic. As well, some of our paramedic partners in Lanark County and Cornwall, Stormont, Dundas, Glengarry were able to promote acting fast, calling 911 for symptoms of stroke on their ambulance vehicles by applying decals with this messaging. The second stroke prevention topic I'd like to share has to do with the diagnosis of transient ischemic attack, or TIA. The diagnosis of TIA is quite complex. In TIA, an artery in the brain is temporarily blocked, leading to transient stroke-like symptoms that come and then disappear and provide a warning of a person's future stroke risk. We often provide the analogy that a TIA is to stroke what angina or chest pain is to heart attack. Unlike heart attack, however, where there are blood tests that can measure cardiac biomarkers in the blood and quickly determine if a person's had a heart attack and how seriously the heart was affected, TIA doesn't have that luxury. There's no easy test, and it often doesn't leave a trace on brain imaging. And so it really relies on the patient's description of their event and the neurologist's assessment relating common patterns of brain artery blockage and the presenting symptoms. Keeping in mind that not everyone who has chest pain has had a heart attack, also not everyone with sudden neurologic problems has had a stroke. In some cases, symptoms which sound like they might be transient ischemic attack end up representing other things like migraine, seizure, inner ear problems, nerve problems. And so a careful history and examination is critical to diagnosis. We have identified through our research that non-stroke diagnoses actually account for 4 out of every 10 patients seen in the stroke prevention clinic. And this number is consistent with what we see in other parts of Canada. So we've been working to improve our understanding of the factors associated with confirmed diagnosis of TIA and stroke. This will help us create more streamlined approaches for urgent testing for patients at highest risk of recurrent events, as much as possible to prevent strokes from occurring. Linked with this project, we've been working with our emergency room partners on a project looking to see, among patients who come and present to the emergency room with TIA, who is at highest risk for stroke in the days following their event. And this has led to the development of the Canadian TIA score. And this tool has been used to help guide emergency healthcare providers across Canada in completing essential testing while the patient's in emergency, things like heart rhythm testing, both brain and blood vessel imaging, and blood tests, and then linking patients deemed at highest risk of stroke with stroke specialists as soon as possible so that interventions can be taken into account. The final research project I'd like to discuss is focused on rapid services for reopening of narrowed arteries that provide essential blood flow to the brain through procedures called carotid stenting or carotid endarterectomy. There are 4 main arteries that deliver blood flow to the brain, 2 in the front and 2 in the back. And it's the 2 in the front that are candidates for surgical intervention. International guidelines recommend that surgery or stenting to reopen narrow symptomatic arteries, that is to say arteries that have recently led to TIA or stroke symptoms, should occur as soon as possible, as this is one of the most serious causes for recurrent stroke. However, we know from looking across Ontario that this actually hasn't taken place very often. So only 10 to 40% of patients actually meet the targets for getting this urgent intervention. So our team, along with our surgical colleagues, have invested significant energy in the past several years to improve this outcome for patients in Champlain. And we've identified these 3 key factors that seem to help patients get to surgery as soon as possible. So the first is prompt patient presentation to an emergency department as opposed to patients presenting to primary care providers. The second is getting early vessel imaging, vascular imaging. So not just imaging the brain, but also looking at the blood vessels rapidly after event so that we can identify if there's a problem there that needs intervention. And the third is about collaboration. So sometimes patients would be seen in emergency and then referred on to a neurologist who would then refer on to a surgeon. We know that that's not good enough. An emergency provider has to alert the stroke specialist same day, who has to involve the surgeon and the interventionalist same day. And that's really how we can achieve tighter timelines. So these strategies have been integrated into our protocols and regional algorithms all across Champlain. And we've been able to improve that timely access for our patients to carotid intervention from 8% when we first started our research to 75% getting their procedure in the desired timelines. So I understand we're going to hold our questions until the end. So I'm welcoming any questions that you have and ideas about stroke prevention later on.
Thank you, Sophia. That's excellent. So I think what you guys are seeing here is that there's a type of research where you come up with new treatments and whatnot, and then there's a whole other branch of research where you're making sure that the treatments that you know work are actually being done. And it sounds like that should be a no-brainer, no pun intended, but that's not the case a lot of the times. And Sophia's work has been fantastic in that, and not only does it help us identify the things that we need to use to triage people, meaning to figure out who needs to be seen really quickly, but it also captures where there are deficiencies in the system or in people's behaviors, whether it's the clinician or the patient or their family, that need to be addressed to give everybody the benefit that we know is out there with these therapies. So Sophia's done some fantastic work, and we'll come back and see if we have some questions for her. But we're moving to our next speaker. A question that will come up is, well, hold on a second. Who are these people that are being involved in the research? That's us, right? That's the people of Ottawa. And how does that happen? How is it that we involve patients in the emergency and in the prevention clinics and whatnot? And that's where I'll bring in Dr. Shami to talk about sort of the engagement side of things. Dr. Shami and I work together very closely. In fact, we share a wall. COVID's been good to us because the distance has made our relationship stronger. Dr. Shami is an attending neurologist at the Ottawa Hospital. He's an associate professor at the Department of Medicine and the University of Ottawa Brain and Mind Institute. He's the director right now of the Ottawa Stroke Program, the scientific director, and he is the new director of the program in medical ethics and humanities in the Faculty of Medicine. So he's a researcher whose work focuses on stroke, on ethics, clinical trial, and acute care. His research is supported by multiple agencies, including the National New Investigator Award from Heart and Stroke Foundation and the CIHR, and of course, the Brain and Mind Research Institute. And I'll say, actually, all of us have received grant funding from the Brain and Mind Research Institute, which allows us to do what we do. So Dr. Shami, please take it away.
Thanks, Dart. It's a pleasure to be here. Good evening, everybody. Get these slides open for you. Is that looking all right? Great. So welcome and thank you all for your support of stroke research and the Brain and Mind Research Institute. The kind of developments that Dar has been telling you about, for example, the ESCAPE trial, these could not have happened without the participation of patients in clinical research trials. And yet it's not a straightforward thing to be able to conduct clinical research in the stroke setting in which we are including patients. It's now a universal requirement and a good one that patients need to provide consent to participate in clinical research. And this is unfortunately the product of the fact that medicine has a blemished history regarding research conducted without consent. the problem is that in acute stroke trials, it's not as straightforward as it might be in oncology or other disciplines to go up to someone and say, hello, madam, hello, sir, would you like to participate in this study? Because our patients are very often unconscious or unable to speak and understand. The patient's next of kin may be unavailable, which has been increasingly the case in the COVID era, where family members are not allowed into the hospital and into the emergency department. If they are available, then often it's a distressing thing to all of a sudden see their husband or wife be disabled by an incapacitating stroke. And some family members have even described this process as being traumatic in and of itself. The other side of the story is that consent forms to participate in research, if any of you have ever seen them, nowadays run up to 15 or 20 pages long. And that is a major barrier to the kinds of decision making that we need to make in a matter of minutes. As Dara alluded to, we get the page from home, get up out of our beds in the middle of the night, and we're aiming to be in the hospital within 20 minutes and making that decision about what is the best treatment for that patient within 5 to 10 more minutes. So what do we do if the question is, we need to conduct a new randomized trial to advance care to figure out what is the best treatment for this particular patient? Should consent be obtained from a surrogate decision maker when possible? Should it be deferred, meaning that we enroll the patient quickly and then ask someone after the fact? Should consent be waived entirely, in which under certain circumstances we just proceed with enrollment? Or can we try to get some consent done in advance? The answer to this, of course, is to do research about how we do research. And that is really something that I'm interested in and has been the source of the work that we're doing here at the Brain and Mind Research Institute. As I alluded to, one of the options is to enroll patients using something we call deferral of consent. And in deferral of consent, a patient who's eligible for a clinical trial is identified and enrolled first, and then is asked to consent after the fact. And the goal of this is to save time, to get that potentially life-saving treatment administered as quickly as possible. But this is not an approach that's allowed in all jurisdictions. For example, 15 minutes away across the bridge in Quebec, deferral of consent is not allowed. In some countries, such as Germany and Australia, it is not allowed. So we're really dealing with a complex landscape. The other thing to think about is it's really not straightforward what it means to say you've given consent to something that's already happened. If a treatment has already been administered, is asking a patient after the fact if they were okay with it really the same kind of permission? So we've done research with patients enrolled in these trials to try to figure out where they stand on these issues. In the Spotlight trial, which was a national study of patients with intracerebral hemorrhage, that orphan disease that Dr. Daulat Shahi referred to, led out of Toronto, in which we were major participants, 90% of the patients and family members we spoke to in that study agreed with the use of deferral of consent. But in the ESCAPE trial, again, that international study led out of Calgary, 80% of the patients surveyed in that study did not agree with the use of deferral of consent to enroll themselves or their loved ones. Throwing another monkey wrench into the situation is does it really save time to enroll patients by deferral of consent? Some work says yes, some work says no. And so when we were sitting down to design the next generation of clinical trial, the ACT trial that is looking to study this new clot-busting drug that Dr. Daulat Shahi was talking about, we said we need to do it by deferral of consent because we need to ensure that we're quick and that we're enrolling every eligible patient. But how do we do it so that we are doing it better? And so this became the topic of our research. So we thought that the best ways to do this would be to involve patients with lived experience as much as possible, to provide standardized, organized information documents to patients and their families, and then to survey patients and their families about the whole process. In the course of thinking about this trial, we came up with a new idea. We call this advance consent. And this has been the topic of our research over the course of the last year or two, and has received a preliminary funding from CIHR, the Canadian Institutes of Health Research. The idea with advance consent, or action as we call it, is to identify patients who are at risk of having a stroke and invite them to provide consent to participate in a clinical trial in the future, should they ever be eligible. For example, a patient seen in the stroke prevention clinic by Sophia could be invited to speak to a research coordinator, discuss the trials that are currently active, and then the patient could agree or choose not to agree to participate if she or he were ever to have a stroke over the course of the next year or two. And if that decision is made and it's documented in the electronic medical record, then the acute care team arriving from home or coming down to the emergency department in minutes flat would know exactly what to do and whether that patient could be enrolled in the next generation cutting edge trial as soon as possible. So we've been studying this option as the next generation of clinical trial consent practices, and our local numbers are very encouraging. So we think that we could probably enroll over 100 patients into clinical studies using this mechanism if it were just adopted in the stroke prevention clinic. We've looked at a systematic review of all available experiences with this kind of study and found that we really would be the first in the world to be doing it. We've surveyed patients enrolled in the ACT trial about their feelings towards advanced consent, and 80% were in favor of going forward. We're also surveying patients from other contexts, physicians, and regulators about the process. What would I like you to take home from this brief presentation? We couldn't do the clinical trials that advance stroke care without our patients' involvement, and it is an active topic of research about how best to include patients when time is of the essence. We've started this work on action using funding from CIHR, but we're just beginning this process. And if you're interested in supporting this work or speaking to us as part of focus groups or interviews, we need to hear from you, people who are interested in the process. Please feel free to reach out and be in touch and ask your questions tonight or in the future. Just a final shout out, thank you to all the healthcare workers who've kept us safe over the course of the pandemic, to the patients who inspire our work, to the colleagues who work alongside us, and to our families who support us. Thank you so much, and I look forward to speaking to you in the question and answer period.
So, I mean, you guys are getting a glimpse into the complexities of what it is that we do. It's not just prevent and treat, and it's not just find new ways to implement prevention and new treatments. It's even looking at the ways that we do the research in the first place, and speaking to the people that have the disease and the loved ones that are taking care of them, and the people who have lost, and asking them, what can we do better? What is it that you want us to do? And how can you join us so that we can change this thing in the future? Now, I'll move on to our next speaker. And again, we're going to come back. When Michelle speaks, there's often a lot of questions from the audience about how we do things. So please keep those in the Q&A, and we will be coming back to them. We're going to move to our next speaker. And here I want to speak to the training that's involved. So how did these people become who they are and what they do? And I remember reading a book about 20 years ago called So You Want to Be a Brain Surgeon. I am not a brain surgeon. Turns out that was too easy and simple a lifestyle. So I decided for something a little more complicated and cerebral. But to give you an idea, we have one of our students, Dr. Lund. So Rhonda is going to be speaking about her journey as a neurology resident and researcher with the Brain and Mind Institute. So in addition to doing all the research and bringing researchers together, Brain and Mind Institute trains undergraduate students, graduate students, physicians, nurses, allied health, you name it. They are all part of the Institute as long as they have the common goal of enhancing the science of brain health and brain knowledge. So Rhonda is what we call a PGY5 resident. That means that she has already finished undergraduate training, has a medical school graduation, and she is a physician, and she has done 5 years of subspecialty training in neurology already. So she's part of the adult neurology program here in Ottawa. She's concurrently in the Royal College's clinical investigator program. So for people who don't think 5 years of subspecialty training is enough and would like to add on another 2 years, she is doing that. And during this time, she's also getting her master's in epidemiology. She was a chief resident during the neurology program last year. She's currently the chief resident of the clinical investigator program, and her research are in the area of stroke and epidemiology. For a person who's done nothing but sleep in hospitals and save lives the last 5 years, she already has 30 publications and has presented at multiple international conferences. It's been an absolute pleasure to work closely with Rhonda, and I'll ask her to take it away.
Thanks so much, Dar, for that very kind introduction. I'll just get my slides up here. Do you see my notes or just the slides, just to be sure?
I can see your slides.
Okay. All right, so I'm Rhonda, and it's so nice to be able to speak to you tonight. Thank you again, Dar, for that very lovely introduction. And I'll be providing a bit of a different perspective. I'll be providing the trainee perspective today in terms of my experience as a resident physician and a junior researcher with the Ottawa Stroke team. So to give a little bit of background, my family and I are actually originally from Calgary, and you might be wondering what a Calgarian is doing here in Ottawa. And it's without a doubt because I believe that the clinical and research training provided to residents here at the University of Ottawa Brain and Mind Research Institute and the Ottawa Hospital Research Institute is some of the best in the country. And I'll be speaking to why that is. So I graduated medical school from the University of Calgary in 2017, and I was fortunate enough to have gone through the match process for residency programs pre-COVID, meaning as a final year medical student, we had the opportunity to visit schools that we were potentially interested in and work at their hospital for 2 weeks. And that was my first time ever coming to Ottawa. And to be honest, in the beginning, I wasn't entirely sure that I wanted to move to Ontario and be away from my family. But it was when I got to interact with the amazing clinicians, researchers, and teachers here at the University of Ottawa Brain and Mind Research Institute that I quickly changed my mind. In fact, Dr. Shami, who you just heard from, was the doctor that I worked with here in Ottawa on the inpatient stroke team. And I still remember my first day here like it was yesterday. There were many stroke codes and we were extremely busy. And like you had heard earlier, a stroke code is an emergency situation where time means brain. But despite these time restraints and many responsibilities, Dr. Shami took me aside and did dedicated teaching with me on how to perform a focused clinical assessment, even in the acute situation. His compassion for patients, passion for medical education, and dedication to improving stroke care really struck me with awe. And it was really at that point that I knew that this was the center that I wanted to train at. And lucky for me, I did end up coming here. So coming into residency, I knew I was very passionate about stroke, but I didn't know what the path to becoming a successful academic stroke neurologist looked like. I hadn't done very much clinical research prior to starting residency, but I knew that I wanted to do more than just clinical neurology. I wanted to know why we do things the way we do them, like why do some people have strokes and recover and others don't? Why do we treat certain people with this medication and others with that? And it was around then that I found Dr. Delashaki as a mentor. He saw that I was excited, driven, and hardworking and took me under his wing. And one day after we had a very long discussion about how we can improve the way we prognosticate the clinical trajectory of patients with hemorrhagic stroke, which is a type of stroke with the highest morbidity and mortality, we came up with a project idea together. He taught me how to perform statistical analysis, how to think like a researcher, how to formulate scientific questions, and more importantly, how to answer them. Under his guidance, I was able to present the results of my first scientific paper at an international conference in Spain. In fact, this picture on the right, we are actually in Granada in Spain. And that paper was subsequently published in our flagship journal, Stroke. Following the publication of my first paper, I was excited and I felt this passion that I've never felt before. I was excited to learn more and do more. I became interested in clinical research, biostatistics, and epidemiology. And under the guidance of Dr. Delashaki, I successfully enrolled in the clinical investigator program with the goal of obtaining a Master's of Science epidemiology degree. And I'm very lucky to be here at the University of Ottawa and have Dr. Delashaki as my primary thesis supervisor. As you heard earlier, I now have 30 publications and have presented my research at 12 different conferences. Furthermore, I think what's even better than that is that I am excited to come to work every single day. I'm excited to share my ideas with my mentors and peers, and I am so grateful that I work at a center where my mentors are not only world-class stroke researchers, but they are humble, kind, and willing to teach, and they view me as a future colleague and not as a trainee. Not only are they passionate about what they do, but they are enthusiastic about what I do. They take the time to listen to my ideas, no matter how big or how small, and they see to it that my research and career goals are being fulfilled. I just want to say I've been so fortunate to have trained here for the last 4.5 years, and I truly believe that the mentorship that I have received here is second to none. Without these amazing people, I would not be the aspiring clinician scientist I am today. Not only have I gained so much clinical knowledge and research skills, more importantly, I have felt valued, heard, supported, and appreciated as a trainee. The Ottawa Stroke Group have made me feel like I'm not only a member of the team, but I am a valued colleague with similar passions to advance stroke research, improve patient care, and train the next generation of researchers and clinicians. Thank you so much for listening to my presentation.
Thank you, Dr. Lund. That's awesome. I mean, as you guys can see, we're incredibly proud of our trainees like Rhonda. We have so many, so many with the Brain and Mind Institute in the labs, in the clinics, in the Emerge. And one of the ways that we measure success of a research program is who we train and how they do moving forward. That includes the people that we train that go into pure clinical care, opening up clinics and seeing patients and saving lives, as well as those that go into universities and advance the science behind the research. Every time we seed one of our Ottawa trainees somewhere, that's another piece of success for the Brain and Mind Institute. And it's like hitting a domino, and it has its own effect, because then they go on and they create this incredible magic out there and inspire so many others. So Rhonda is one of our most successful ones in that she is currently being approached by multiple institutions. And again, when people talk about, oh, I went to the Harvard and the Mayo, well, success is not going to Harvard and Mayo. Success is when places like those, or in Rhonda's case, Stanford, actually come to you and beg you to come and offer to pay you money, which is exactly, she's fending off these places. So that's how you measure success, okay? It's who comes to you. So that's Rhonda for us. And we're going to come back and ask her more questions. Speaking of the trainees and the support, so one of the things Brain and Mind does, of course, is it makes grant programs, which makes all of our research programs possible, but it also does fellowship and scholarship programs. So residents and fellows and trainees and postdocs and graduate students and even summer students, they can all receive stipends and scholarships through the Brain and Mind, which basically pays them to be able to do research and gain their skills and build their experiences. Some of those are in the labs, and that's a huge part of the Brain and Mind Institute, are those classic scientists in the labs with the test tubes and the stem cells and the really fancy chemicals and whatnot bubbling in the background. That's all real and that's all here. So that's where we'll shift to, is the future. Now, what I'll preface is, when we look at what we're doing today, even the clinical trials that are going on that are going to inform our care of patients in about a year or two, this is all actually based on research that was done 10 to 20 years ago in labs. It all comes from labs. So what we're doing now and taking credit for the big advances was all the work that those scientists did back when no one else had the vision to go looking at these things. And we have those scientists at the Brain and Mind Institute, the ones with the vision, and they're ones that are doing the things right now, just down the hall, that are going to be changing the world in about 10 to 20 years. One such person is Dr. Lagacé. So Dr. Lagacé is an associate professor and neuroscientist with our Faculty of Medicine. And she's the University of Ottawa site leader for the Canadian Partnership of Stroke Recovery. She obtained her PhD originally at Dalhousie. Then she went to University of Texas, Southwestern Medical Center, to do her postdoctoral training. So she's a leader in studying stem cells in the brain. Those are your own endogenous stem cells, not the ones that you can go buy in a supermarket. But these are the real stem cells that we have. And she's going to share with us the lab work that she does in the hope of developing new ways to improve the lives of stroke survivors. So Dr. Lagacé, take it away.
Thanks so much, Dar, and good evening, everyone. Thank you for taking the time out of your night to join us today. And I'm just going to get my slides here for you on your screen. Okay, hopefully all good. All right, so it's really my pleasure to tell you about some of the work in the Mind Research Institute that's being done within the labs, even though I'm here home tonight, that we're really trying to ask the question, how can we repair the brain after a stroke? So many of you may have been taught or even still think that the brain is really static. In other words, after you develop a certain number of neurons and connections. And if you have an injury or if you have a stroke, that you're going to have long-term disability because you can't create new neurons or new pathways. And this is why, for a long time, we really thought that it was going to be very hard in terms of cell replacement to repair the injured brain. The lucky thing for me is that I don't have to teach that anymore. It's also lucky for all of us. As I age also, I'm very glad to know that my brain actually has a lot of plasticity within it, and we call this neuroplasticity. So it's really the ability of the brain to reorganize itself. And this can be both in terms of structure and also in terms of how it functions. In fact, neuroplasticity is the reason why we have improvements after stroke, even when there's no treatment given. So you may have just thought to yourself, did I just hear her say improvements after stroke with no treatment? If you've had a stroke, you might not be surprised by this, but I know many people remain extremely surprised by this. And that is what I'm talking about. So we know that after a stroke occurs, that initially there's a loss of many functions within the body. But what we can see is shortly after the stroke, I'm showing it here as spontaneous neurological recovery, we have recovery of function. And this occurs mostly right after the stroke occurs. And then you can see that though it's disappointing because it doesn't actually bring it up to the same level as the person functioned before the stroke, and it doesn't always occur to the same degree in different patients. Thus, myself and others really want to understand, why does this spontaneous biological recovery happen? What drives this? Because if we could understand this, then we could harness that potential and utilize and make new treatments that would be able to either extend that recovery or allow it to happen quicker and more effectively in more patients. So in the labs in the University of Ottawa, including in clinical labs and in basic science labs, many people are trying to understand what are the changes that occur within the brain after stroke. So in clinical labs and also basic science labs, this picture up here on the left top is really showing, we're looking at different areas that are activated. So, when I move my right hand, my left brain is active up here, which is this big, red, orangey spot here. But after I have a stroke, what other regions of the brain now become activated and take over for that? And it's very similar to what happens if one of your limbs is removed, or if an injury happens in your limb and you no longer have sensations there. The areas that are for your other limbs or your fingers then take over, and they're represented within the cortex. Other labs, including my own, are very interested in the different cells and how within the different cell types within the brain. And we're discovering every day, yes, we always knew there was neurons and astrocytes, but the subtypes of neurons now, there's over 30 types of different neurons within our motor cortex. How are these different groups of cells, which we can now isolate and look at, really involved in stroke recovery? And as well, we're interested in the vessels themselves. So Dr. Baptiste Lacoste, for example, has a whole lab just studying how we have regeneration of vessels and how those occur in terms of treatment. And could we make a treatment that actually targeted those vessels within the brain? And then there's also labs looking at individual neurons, looking at really down at a magnified view of actually the synapses. So these are the little things at the ends of the neurons, or the processes, the dendrites, that actually signal between the neurons. And how are those changing after stroke in Dr. Jean-Claude Baïk's lab? And together, we're discovering then what is the big overall changes that are occurring after stroke, and how can we capitalize those when patients are recovering to have more people recover following a stroke through new treatments. So what I want to talk to you about today, as Dar mentioned, is one of my own areas of research that my lab is really interested in. And I became interested in this when I actually first looked at this brain slice underneath a microscope. So this is a mouse brain, and we can see these newborn cells within the brain. So this is the lateral ventricle of the brain. And these cells actually have migrated up on their own to surround the stroke. So you can see thousands of cells actually surrounding the stroke. Now, those cells are there, but the animals still have impairments very similar to the impairments in human, in motor function, and in some cases, cognitive function. So what our lab one question we're interested in is, can we harness the potential of those adult generated cells, those stem cells in the brain after stroke by stimulating them? Now, you might say, how do you stimulate those cells? And this is where preclinical models, so work in animal, rodent models, have the unique ability to be able to actually stimulate individual groups of cells. So we have created a transgenic mouse model in which we shine light through a process called optogenetics, where we can stimulate just the newborn cells after stroke. This actually method was discovered in Stanford by Dr. Deseroff, and we are doing this in Ottawa to understand then how can stimulation of these newborn cells improve recovery. We can stimulate the animals within their home cage, and animals also can be stimulated similar to patients that sometimes are stimulated with non-invasive treatments when they're actually performing a task. So when we do these studies, my students and I want to understand how can we improve function. So in this case, one simple task we do is we actually put a piece of tape right on the mouse's paw. And then we see how long does it take them to remove that tape on the injured arm, and then also on the uninjured arm, using their uninjured arm. So hopefully you can see on this graph here at the bottom that it takes about 10 seconds for a mouse usually to remove a piece of tape when you put it on its paw. They're pretty good at this task. They don't like things on their paws. 1 week after stroke, so WPS, 1 week after stroke, you can see it almost takes them a minute on average to remove the tape. And this is the same in animals, whether they're stimulated or not stimulated. But if we stimulate those newborn cells, you can see 4 weeks after stroke, those animals that are stimulated, this blue bar, right? It's now only taking them about 30 seconds to remove the tape, where those animals that didn't get the stimulation are taking longer. Again, a little bit better. They've recovered a little bit on their own, but not as much as the animals that got stimulation. When I show you this result, I know when I talk to my own family about my results, the question you have to be asking is, that's super interesting, but this isn't a mouse. How are you helping patients? Believe me, both my grandmothers suffered a stroke, and I know the need is great. Both of them actually had more than one stroke and had a really tough life at their end of their life. And we're really fortunate that actually also in Ottawa, there's what's called the CanStim network. And one way, this is one way that our discoveries using optogenetics is also being translated into changes and understood how we can affect clinical work. We're fortunate that Ottawa is the hub for the CanStim trial and network, which is led by Jody Edwards, also an investigator at the University of Ottawa and member of the Brain and Mind Institute. And they've already began to actually publish some of the recent findings this year to show consensus recommendations across Canada, and are now beginning stimulation studies using transmagnetic magnetic stimulation, so TMS, to improve stroke recovery. So it's exciting that we can meet with our clinical colleagues, discuss our findings in basic science, doing things that we can do that they can't do in humans, and we can help them understand when they stimulate using TMS, What are some of the different effects they're seeing on the different cells that they're stimulating? And this team, the CanStim team, is just one of the many teams that I'm very honored and fortunate to be part of. These are some of my colleagues at the University of Ottawa, basic scientists that also work on stroke. And I truly believe together, everyone achieves more. I'm also very fortunate, and I wanted to show you at the last, my own team, and these are all my trainees, okay, also my children. They don't do any lab work, although they do hear about the lab work, who do all the hard work in the lab. We're very fortunate to have so many trainees. I'm very proud to teach them and also to lecture the next generations of researchers, as well as thankful for all the funding that I received. Not only the Brain and Mind Research Institute, which has given scholarships to my students, but also our partnerships with the Canadian Partnership for Stroke Recovery, CIHR, and NSERC. So again, I thank you once again for joining us tonight and being interested in our science. I look forward to the questions that you have. And if you ever have any questions about anything about basic science and research studies in stroke recovery, don't hesitate to contact me.
Thank you, Diane. That was awesome. And just some really cool stuff. You know, when you look at this stuff, you think science fiction, and then that's how you know that it's super current, cool science, and just amazing stuff. I haven't done any lab type research in so many years, and then when you hear what these guys are doing now, it's mind blowing. And that's all again happening here, which is so fantastic. I do think you should get your kids in the lab with you, however. And I am trying to get my kids to take the pager for a night or two. They're not doing it. But this is a challenge we all face in addition to the others. So at this point, I think we've heard from all of our speakers, and thank you everybody, and thank you for the attendees. This is a good time. I'll turn it to Natasha Hollywood, who will be picking up some questions from the audience. And again, please, if you guys have questions, throw them into the QA, and Natasha will do her best to ask the panelists on your behalf.
Thank you, Dr. Dar, and thank you everyone, and thank you all speakers. And so I'll just kind of go ahead and start asking the questions as they pop up in the Q&A. So maybe the first one could be for Diane Legacy, Dr. Legacy. Fresh off of her presentation. So Dr. Legacy, why do the stem cells that are made after stroke not improve stroke recovery on their own?
Yeah, it's a great question. So the stem cells themselves, so once they migrate up, actually it's really interesting that most of them actually end up dying. So about 80% of them actually die once they migrate up there. So we think part of the reason why they're not as useful as they could be is because they can't really incorporate into the circuitry, and they're not getting enough support surrounding that stroke area to be able to really function. And we think a part of what we're doing when we're stimulating is helping to activate those cells to get them to engage.
Thank you. And maybe as a follow-up, are studies being done implementing stem cells after stroke?
Yes, so there are studies looking at stem cells and stroke recovery. So the stem cells that I was talking to you about today are the same as what Dar was mentioning to you earlier, are the endogenous stem cells. So these are ones that actually we can't see, to be honest with you, in the live human brain. We actually can't image and see those cells in the live human brain. There are, though, other studies being done that are looking at transplanted stem cells, so other types of stem cell therapy where you transplant cells. And there's lots of exciting work in this area with new clinical trials coming out.
Thank you. Our next question to Sophia Gokin. What do you expect to be the next big breakthrough in stroke research? Stem cells, artificial intelligence, and imaging? Any other suggestions?
You'll have to unmute yourself, Sophia. I think you are unmuted. I'm not sure if it's a software glitch.
No, we cannot hear Sophia this time. Sophia, can you remute and unmute again? There we go.
That's another question while we wait for Sophia to get her audio back going.
talk a bit about that.
There we are.
Oh, there you go. Good. Perfect.
I was thinking that some of the rapid work that's being done in our region might be nice to highlight.
Okay, so Dr. Dar, how long does it take for new treatment go from the idea stage to research study to standard of care?
So the idea stage, if it's really, really new and fresh and out there, and it's kind of in where Dr. Lagasse's work is, that can actually be there for a decade while people refine the idea and turn it into an actual treatment and whatnot. But once you got sort of more of a practical concept, like we have this drug or we have this tool, and how does it happen? Well, there's about a 2 to 3 year period where you have to go get funding. And that's actually the biggest limiting thing, right? So you can't just show up and say, all right, ready to go. Now, because ready to go means you need about a couple of $1 million, okay? And that's the only way you can do these studies, because they're worldwide efforts and you got to pay everybody, right? Everybody, no one's going to work for free over here. So it's a practical reality of the situation. So then there's the process of getting what we call seed funding. Very much like any business, you've got to start with little tiny pockets of money to start showing some early data and proof of concepts. And then you take that to a bigger agency like a Canadian Institutes of Health Research, where you can actually get $1 million or $2 million. If you get very lucky, some incredible philanthropists will come in. You know, if we get somebody from Microsoft or Tesla popping in and giving you $5 million, that's fantastic, but that rarely ever happens. I mean, some of our folks here in Ottawa have received Bill and Melinda Gates money, but that takes about 2 to 3 years, just that part, to get sufficient funds to launch the study. Then once you launch the study, depending on the type of study you're doing, so the stroke studies we do can take on average 2 years, maybe 3 years, especially if you're big enough that you can go international so that you can really get a lot of data in a short period of time. So from using the one where we did the thrombectomy, the pulling the clots out of the brains, the conversation was 2011. It was never properly funded, believe it or not. The Canadian government agency, which are made up of scientists like us, said this will never work 3 times in a row. And by 2013, the investigators managed to secure their own funding from private enterprise and some donors. And then from 2013 to 2015 was the study, and 2015 it became standard of care. So that one was about 4 to 5 years.
The next question is to, I'll let you decide, maybe Daria can help direct the question to who the best person would be to answer it, but would love to hear about any research that's being done on interventions that can benefit clients, their therapists and care teams, specifically at the rehab stage of stroke recovery.
Yeah, I mean, we'll get everybody to jump in. Michelle, maybe you want to, Dr. Shamby, you want to take this one?
I'm sorry, I couldn't hear the question.
Would love to hear. Can you hear me? Sorry.
Yeah, thanks.
Okay, it's in the Q&A too, Michelle. If you click on the box, you can actually read it. Would love to hear about any research that's being done on interventions that can benefit clients, their therapists, and care team, specifically at the rehab stage of stroke recovery.
Sure. Well, it's ironic Dar's asking me to speak about it, because really this is his brainchild, is an idea that we call Recover Now. So Dar is a world leader in research into intracerebral hemorrhage, but at the same time worked with colleagues here at U Ottawa and Brain and Mind to come up with this idea of trialing particular apps to supplement the rehab that was already being done. You know, we're fortunate in Canada that everyone who needs rehab gets it. That's not the situation in the United States, but wait lists are long and patients can end up waiting on the hospital ward to get to the rehab that they need. And so we saw this as an opportunity to trial a randomized trial in which half of those patients waiting would get a special tablet with apps that we had co-designed in order to supplement their rehab. And that is ongoing. It's spread now to Toronto. Toronto and Ottawa are leading this trial as a feasibility exercise to see if we really can get this done. Can we find the patients, and can we make this something that we could then take to the CIHR or to other funding sources to be able to turn into $1 million, $2 million clinical trial. That's just one part of things that the stroke group here is doing with regards to rehab research.
The next question could be for anybody else to weigh in on that? No? Okay. So maybe Dr. Lagacé, has development of the brain and mind resulted in an acceleration of science? From science from bench to bedside to practice? Sorry, I'll get some water.
Yes, so that's always our goal for sure, and I think it has helped. You know, you can't really measure, like, you know, everyone does one or works on different projects in labs, right? And it's not necessarily like one little thing that I could point to that directly correlates to maybe a change within clinical practice in a big way, you know? So we're all adding in the pieces of the puzzle in terms of how is it that the brain changes after stroke, which then helps other researchers to add other pieces to that puzzle. And then together, you know, we ultimately try to change clinical practice. So, I mean, I could give you, I guess I'm just sort of also thinking off the top of my head, like, you know, there was work done with the Brain and Mind Institute and with Dale Corbett, for example, and he did preclinical animal studies where he really looked at, you know, how do animals do in rehabilitation in different environments at different time points with different intensities. And some of those studies, I think, directly ended up correlating in terms of what happened in terms of how clinical trials were then designed. And I'm not sure if Dar wants to add anything else on. So it's not always easy to kind of point to my research paper is this, and that's how it directly changed. But there's lots of, you know, I think the bigger thing is that we're all adding in pieces of the puzzle to understand ultimately how to improve stroke recovery.
Yep, I agree completely. And Dr. Corbett example is a fantastic one because a lot of his work and his work with the brain and mind, he was one of the first scientists to get in there, really sparked the whole get the scientist and the clinician and the clinical researcher together in a room together and say, this is what I saw in the lab. Well, this is what my patient is asking me. Well, this is how we put that all together. You can't time it because I don't know when the stopwatch started and when the treatment was done. You actually can't. But what I can tell you is that the brain and mind, you know, this takes me back to, so Diane, you just remind me, it takes me back to the very beginning of the brain and mind when I'd heard of Dale Corbett, who was a scientist in recovery and stroke. And he'd heard of me, and we'd been both living in Ottawa forever and never met each other, ever talked to each other. And the director of the Brain and Mind Institute at that time literally made us both book an appointment, brought us to his office, put us in a room together and goes, Dar, this is Dale. Dale, this is Dar. And he goes, I'd like you guys to start working together right now. And we were like, okay. And then he turned to us and said, so what's your idea? Just like that. And that was the start of the Recover Now project. So I can tell you that we can't measure that, but we can definitely feel the momentum and the acceleration of the effort and the excitement and the energy.
This is for Dr. Lund. So Rhonda, why did you choose to train at the Brain and Mind and the Ottawa Hospital Research Institute, and how did it help achieve your goals?
I chose to train here for 3 reasons. The first being the people. I think the people here have just been the most incredible mentors. I really, truly would not be this aspiring clinician scientist, like I said, if it wasn't for the amazing mentorship that I've had. And I don't even think I realized that I had this academic potential until I met these amazing scientists and teachers here at the Ottawa Hospital. The second would be the collegiality. I think everyone here can agree that working with the neurology program and the Calgary Stroke program, everyone is so supportive and just so collegial, and no one is in it for themselves. It's all about teamwork and working towards one common goal. And I think that's really unique when you are in an institution as big as the Ottawa Hospital. And lastly, I would have to say it's just been the most supportive environment. I think that whenever I've had any adversities come my way, there's the support that I've had, and the encouragement and the advice that I've been given has all been just very genuine, and I just feel very lucky to be in a place where I feel really valued. And I don't think I would have had the opportunities to get my fellowship position, like Dar had mentioned earlier, at Stanford, if it wasn't for the amazing training that I received here.
This one is for Michelle Batashami. Why is it so important for consent for clinical trials?
Yeah, that's a great question. So, when clinical research first started, in the way that we recognize it now, it was in the mid decades of the 20th century, and it was very strongly shaped by the experiences of Nazi experimentation on people who did not give their consent to be experimented upon. And the medical community was really shaken by the experiences of that era and committed to the fact that patients should not have things done to them. People should not have things done to them without their permission, without their knowledge, without their consent. And unfortunately, there have still been isolated instances of things happening without consent. Some famous historical examples, like the Tuskegee syphilis experiments, in which African-American men were allowed to be untreated for syphilis without being told that they had the disease, just so that scientists could see what happened to them. So we don't want to do that anymore. We want to ensure that patients' rights are protected. There are now national and international agreements, and it's really a question of figuring out the best way to obtain consent from people who are suddenly incapacitated, but who need to be treated quickly in order for the treatments to be the most effective. That's the challenge that we're facing in stroke research.
Thank you. Dr. Legacy, could you please further explain the concept of neuroplasticity?
Sure. So neuroplasticity really refers to the process that we know occurs in the brain where, if the brain is injured, other parts of the brain can take over that role. It can be either through different connections between different cell types. It can also be that different areas of the brain, through what we call diastasis, so different regions of the brain, may help to then perform functions that were previously performed by the area that was actually injured by the stroke. So I saw the person was in the question and answer also asking, I thought this was observed maybe even after World War II and surgery in soldiers. And I think, it probably has been happening for a long time. It's just now we finally have the ability to understand what's happening in terms of being able to look within the brain and see this reorganization. I mean, we can now have methods in our preclinical models where we can look at hundreds of neurons over time and see how are they changing after an injury or in different types of stroke models. So it really gives us more insights into the mechanisms of how this rewiring is occurring and what is leading the way in terms of how that happens. And, it's quite interesting because a lot of that is very similar to some of the mechanisms that we know are important in brain development. So some of the things that happen actually in brain development are re-happening after a stroke, and sort of that relearning concept. Thomas Carmichael just had a recent really big paper on that too. And there's lots of interest in this about how the brain is almost relearning after stroke.
Thank you. Sophia Gokin, what are some of the ways that patients have been engaged or as advisors or partners in research?
Can you hear me okay?
Yeah.
Okay, great. So I'd like to just highlight that none of this research happens and ideas don't happen without patients as partners. A lot of the work that we do begins as a quality improvement project where we're engaging with people there's ideas out there or needs that are voiced from patients, and these then develop into more robust research projects where we're looking at them systematically. More recently, we've been engaging with community paramedics to provide more support with patients after stroke discharge at home, because there's rehab needs, but then there's other monitoring needs and other follow-up that's required. So that's kind of something that's new on the horizon that I think we'll find is a research topic down the road, because people want more support after stroke and need that in their home setting. So it's one of the topics. I don't know if other presenters have some feedback on that as well.
Okay, great. Thank you, Sophia. And then this could have been for Dr. Shani, but he's had to be somewhere else. So where can the public, and this is a good question, where can the public find more information on all ongoing clinical studies?
That's a tough one because there are so many. So a few places. So the Ottawa Stroke Program itself does have a webpage listing the studies that we are currently enrolling in. But sort of the big master webpage is clinicaltrials.gov. What that is a master repository of all what are called registered clinical trials. And to let you know what that is in the old days, you could just say you're doing a clinical trial and let people know once you're doing it, but it's decided that that's not acceptable for a variety of reasons. So what any scientific journal says is, if you're going to report the results of a clinical trial, you should have registered it on this webpage years ago before you even started the trial, saying, what is it you're doing? How is it you're doing it? What are all the parameters? So it's basically open access. Everybody knows what's going on out there. And that way there's no duplication of errors. There's no fudging of data because you say, oh, this is what we meant to do all along, whereas clearly it wasn't. So clinicaltrials.gov has all that on there. So if you go to clinicaltrials.gov, it has a variety of search terms. So if one wanted to know what's going on in their own city, you could put in Ottawa, you could put in Ottawa Hospital, you could put in CHIO, HRI, Bruyere, whatever. It is very technical. Like, it's not going to give you a very easy to understand layout because it's designed for all people, including scientists. So there'll be some technical details in there, but you'll at least get the sense of what the study is, who's running it, and what it is they're trying to achieve.
Thank you. And there are a few more questions, but we'll ask one more just for timing purposes. So the last question would be, what role does our family history have? Stroke potential, is it hereditary? And are there environmental factors potential for stroke, for example?
I think this one is good for Sophia because you addressed this with Bed. This is a common question for you in our clinic.
Thanks, Star. So in terms of hereditary factors and genetic factors, certainly those do weigh in when it comes to stroke risk, but we know that socioeconomic factors also play a big role. So not only do families share the same genes, they also share the same environment. So if we're economically disadvantaged, or if we're an active family or families that have access to food, education, these are things that lower stroke risk. And so hereditary things do matter for sure, our genetics matter, but there's lots of lifestyle things you can do, whether it's reducing blood pressure, addressing cholesterol, being active, eating well. All these things have a big impact against those genetics to reduce your risk of stroke.
Great. Thank you, Sophia. And actually, I've been asked to ask one more question. So your patience is very much appreciated. If you call 911, who determines if stroke is likely and to what emergency will it be taken? Will you be taken? Is acute treatment different in different emergency departments? Very good question.
Yeah, so this is key, and thank you. I wanted to flag that when we have a lot of questions, unfortunately, folks, we can't get to. We had for a while there over 100 participants. We still have about 80 something. So this one though is critical because this can actually save your life, and this will save someone's life that you know. Stroke care is very regionalized. There's very few people that can do these extremely advanced things. For that reason, every region has what's called a comprehensive stroke center. For us, it's the Ottawa Civic Campus is the comprehensive, but what we also have are primary stroke centers. We have several in our region, including Hawkesbury, Cornwall, Pembroke, for example. What these mean is that if you are in your house and you call 911 because you've had symptoms of a stroke, the ambulance paramedics are trained to come up with a really quick assessment to say this may be a stroke. They're not trained to say this absolutely is a stroke and it's this type of stroke or that type of stroke, but they're trained to say this may be a stroke. And they have a bypass that they all have all across Ontario. They have this where they will go to the nearest primary stroke center, unless if you're close to the comprehensive. So if you're in Ottawa proper, you will go to the Civic with that paramedic. If you are out in Almont, or if you're way out in Deep River, probably you'll go to Pembroke. When you get to the primary, they can give you the clot buster, they can do the CAT scans and the CTAs, but they do not have the stroke doctor. What they have is a stroke trained emergency physician with a telestroke system that calls one of about 20 trained stroke doctors, of which I'm one of them, and we cover the whole province. So we pop up on a video, we look at the scans, and we direct the therapy. And then we transfer that person, if eligible, to the nearest comprehensive center for the clot evacuation. I tell you all these details because the number one reason why people do badly with stroke is they don't go for help. And the number two reason, they decide to take themselves for help. Okay, they go to the wrong hospital where they're not trained to diagnose stroke. And even if they diagnose it, they have to call an ambulance to come back to their hospital to put you in and send you to the right hospital while you lose 2 million brain cells a minute. You've paid your taxes, call 911. That's what you paid for. And remember the FAST acronym. That's how we know when someone's having a stroke. FAST, face, one side of your face is droopy, call 911. A for arms is one arm. When you ask a person to lift their arms up, is one arm weaker than the other? Is the leg weaker than the other? Is one side of the body weaker than the other? Call 911. S is for speech. Did their speech suddenly change? Can't talk, slurred, can't get words out, or can't even understand you all of a sudden? Call 911. And the T in FAST is for time. 2 million brain cells a minute. Don't overthink it. Don't wait to see if this gets better in the morning, and don't get in a car and drive somewhere. Call 911. Okay, I think that we just got to leave you with that because that's actually the most life-saving advice.
Thank you very much. Thank you for all the questions from the audience. Greatly appreciated. Now we're going to turn this over to Dr. Slack to close things off. Thank you all the panelists and presenters for this evening. Thank you very much.
Thanks, everyone. That was great. And thanks, Dr. Dar, for the advice as to where to go if you think you're having a stroke. I'd like to thank all the speakers and our moderator for the great discussion tonight. I think we all learned a lot. This entire session will be recorded and it will be available on our website. So if you missed part of it, you can go to the website. I'd also like to thank the Brain and Mind team, Natasha Hollywood, who's our manager, Candace Fortier, who's our administrative coordinator, Sarah Schock, who's our science writer. And if you'd like to support stroke research at the University of Ottawa Brain and Mind, please go to our website or contact us directly. If you'd like more information or to attend some of our events, also go to the Brain and Mind website or follow us on Facebook, follow us on Twitter, and please join us for tomorrow's event. Tomorrow we're going to talk about keeping tabs on COVID, the latest research advancements, because we know that COVID really affects brain health. So we're going to talk about the effect of COVID on mental health as well. So again, thank you everyone for the great discussion and thanks for joining us tonight. Good night.